Called to order. Good morning and welcome to the September 13th meeting of the Douglas County Criminal Justice Coordinating Council. My name is Pam Weejan. I'm the chair of the Cjcc. I want to pass a bit of information along regarding how we will conduct our meeting on Zoom today. We ask that all members please turn on video if you have it. We ask that all members and presenters mute their line when not speaking. We ask that you please identify yourself each time you speak. If you have public comment to make during the public comment section of the agenda, please use the raise your hand function on Zoom. Recordings of the Cjcc meetings are available on the Cjcc website after each meeting. Our first agenda item today will be a presentation about the crisis system roadmap with Dr. Marjorie Yelphor and Dr. Kenneth Minkoff, and I'm going to let them start. Dr. Minkoff, you're on mute.
Yeah. Hi there, everybody. Marjorie, are you going to be able to share screen to present slides, or should I just talk off the cuff? Or here we go. Okay. So, what we're going to do is give a very brief presentation of our report called Roadmap to the Ideal Crisis System that was prepared by the Community Psychiatry Committee of the Group for the Advancement of Psychiatry and published by the National Council for Mental Wellbeing, used to be the National Council for Behavioral Healthcare, in 2021. And Margie and I are the co-chairs of that committee currently, and are responsible for working with the committee, the National Council, and others on promoting the use of this roadmap to help communities like yours all over the country figure out where they want to go and how to get there. Margie and I have been co-chairing as well a pilot learning community, national learning community of 5 local systems that are using the roadmap to help them with their planning and implementation. One of those communities is Douglas County, Kansas. And Bob Cjcc, who has been one of the team members participating in that process, invited us to come and talk to you today so that you guys on the Cjcc can understand what the Ideal Crisis System Roadmap is about, and then use this as a way of thinking, what is the role of the Cjcc and subgroups like CIT planning, and how does that relate to what's the best way for it to relate in an ongoing way to the crisis system planning processes that are going on under the auspice of the county and the clinical service delivery partners in Douglas County. And in relationship to not only 988 implementation, but also to the opening of the new Douglas County Crisis Center. So one of the points that we're making about the road, I'm going to just do this very briefly, and then Margie will pick up on the vision. When our committee got together 5 years ago to start this discussion, one of the things we realized is that that people were talking about crisis services all over the country, but often as an add-on or a Band-Aid to what were perceived as a lack of systemic response. And that lack of systemic response often leads a lot of behavioral health crisis work to be done by law enforcement rather than in an organized way in the medical system, the way we're commonly expecting emergency medical systems to function for everyone in the community. And so what we decided to do was to say out loud that, first of all, it's not enough for us to be thinking about behavioral health crisis system as some sort of Band-Aid that communities could do if they happen to have some extra funds laying around, but that we should start to think about behavioral health crisis system response for our whole community, just the way we think about other essential community services. So what we dared to do in our community was to outline a vision of an ideal crisis system that is worthy of all of us in the United States, And then not only just articulate it as a vision, but we felt an obligation to describe all the specific elements for how to get there. And then all of the measurable indicators of progress that are needed to get there. So starting with, and this is a complex process, just like the 911 emergency medical system and emergency response for public safety. This is not something that can be developed overnight. Communities need to get together to figure out how to do this step by step over an extended period of time. So, but it starts with having a vision. And, you know, so the vision is that every individual and family in every community in the US will have access to a continuum of best practice behavioral health crisis services that are welcoming, person-centered, recovery-oriented, and continuous. Further, that an excellent behavioral health crisis system is an essential community service, just like police, fire, and emergency medical services. Every community should expect a highly effective behavioral health crisis system to meet the needs of its population. And it's more than a single crisis program. It's an organized set of structures, processes, services, et cetera. And that it's designed to be responsive throughout the continuum of crisis response to the person in crisis, all the people around them, first responders, and certainly all the customers that may be involved, including those in the criminal justice system. Now, when you do like sequential intercept mapping under the auspice of the Cjcc, if you've done that, then you know that we're talking about intercept 0 and to some extent intercept 1 in the sequential intercept process. But that intercept is not just a little point on a dot where you come up with a single program. If you're thinking about diverting people out of the system, the criminal justice system, into a clinical response system when they have behavioral health needs, divert to what is an important question, and divert to what is a complicated thing. It's not just a single place. It requires a continuum of response that's appropriately developed in order to be successful getting people who don't need to be in the criminal justice system or in law enforcement encounters into a clinically driven response, just that we would expect for anyone, ourselves or our family members. Next slide. So in articulating the system, there's a set of shared values. And it's important for communities, may not seem this way, but communities often dive into creating programs without thinking about the fact that they're designing a system that's about meeting the needs of themselves, their community, and their family members. And so these shared values are a guiding document for how to design every aspect of the continuum. And I'm not going to go through them right now for the sake of time. I want to get on to the next slide. And what we emphasized in the report is the importance of, if you're designing a system, and actually if you look at your own Douglas County emergency medical system, you will see that even though it functions most of the time pretty seamlessly, there's a whole lot of structure behind it that has been developed over the years, not just for Douglas County, but everywhere. And so we looked at replicating what would need to be successful for a behavioral health crisis system. And we want to say to you clearly, this seems daunting, but it's possible. You don't get there overnight. You get there planfully, just like you do all kinds of cool things in your county, I'm sure. And it has three major elements. The first is an organized mechanism, what we call an accountable entity, to organize and coordinate the planning, implementation, financing, and measurement of progress and continuous improvement of this system, akin to what you likely have in place already for your medical system. One of the things that you guys need to think about is, what is the role of the Cjcc in contributing to the development of that accountable entity, which exists in partnership with the criminal justice system, but essentially is outside of it. It's a clinical system of care that works collaboratively with law enforcement, criminal justice, homeless services, and all kinds of other things, but it's about behavioral health crisis response through the community. And we outline in there lots of specific details about how such entities need to be constructed. And you guys are in a perfect moment in Lawrence, in Douglas County, to take the next step forward in thinking about how you're going to do this in an ongoing way. The second element that is organized through this community collaboration is a service continuum. And it's not just a disconnected array of programs like mobile crisis center, this and that. It's literally a continuum of service that is designed to have capacities for adults and children, for people with different types of complexity, different types of backgrounds, people who have all kinds of funding, people who are in various places within the county, and is able to meet people where they are as early in their crisis as possible and stay with them in a continuing way as their crisis needs may change rapidly. Because crisis is not a one and done encounter. It's something where people need help early and may need help over a period of weeks, sometimes longer, before they can be considered stable enough to participate in what we call routine care. And within that, there's a whole set of specific things that we identify that communities should think about developing in order to reduce the burden on law enforcement and medical emergency rooms and better serve people's needs in an appropriate way. Those include the 988, 911 responses, how they're coordinated, how we use mobile crisis, but we also have walk-in urgent care centers, crisis centers for people who may walk in, but also be brought in involuntarily, continuing ongoing care, both community-based and various types of residential crisis support, people, both adults and children, people who present with mental health requests as well as substance requests, and with people being co-occurring throughout that whole continuum. Now, with the third part of the pyramid here is that within each of those, there are an emerging array of guidelines for clinical best practice that are important to pay attention to in the context of implementing a successful system. And we put those into our report so people would know that they're there. A lot of systems as they're developing get stuck because they don't know what the best practices are. And therefore they design what they do incorrectly. And then that often leads to, creating poorer outcomes than necessary because there are so many internal barriers and lack of appropriate response to people in crisis need. So we put this all together into one document that is 200 and some odd pages long. There's a report card that allows systems to discuss where they are and identify their next steps for strategic planning that Bob and his folks have been learning to use as part of our learning community. And what we wanted to do is introduce you to this today so that you could have some understanding of how to take this, that this information exists, and think about how you might want to use it in small bits, step by step, to inform improving your system for the people of Douglas County. I'm going to hand it over to Margie at this point so I don't take too much time. And Margie can add her spin on how this might be helpful to you because she and her group have been consulting to your system and so they know you guys pretty well.
Yeah, so in each of the different sections, there's more detail. And so when you're talking about this whole accountable entity thing, this really is kind of the foundation for being able to, if we're saying that you need all these different crisis services that align towards common goals and common outcomes, then having some kind of oversight of determining what those values are, what those goals are, and how do you know if people are performing? is kind of the function of that accountable entity, but also it's often tied to how things are financed and, what are the metrics that you're trying to achieve, and who is the service, who's eligible for the service, and that sorts of things. So those are things that, like in the learning community, for example, there was a lot of discussion amongst all the different participants on how do you get the right people at the table. For example, Medicaid is a huge player in terms of financing, and a lot of the communities, needed help in figuring out like how to have conversations with Medicaid, how to bring them to the table, because having them as a whole separate thing is really, Medicaid has a lot to bring, but they need the guidance from the local leaders and system leaders on then what kind of services does Medicaid need to contribute to. And yeah, we're not going to go over all these minute details in this meeting because we want to have discussion, but in the report it goes into a whole lot more detail, and then talking about the array of capacities. Crisis isn't, like Ken said, crisis isn't just one single program. Nationally, there's a lot of attention on crisis services, and it's like almost every day you look at the news and there's a story about, some community did a cool co-responder program or something. And a crisis service is a system is a whole lot more than that. That's just one component. And so, having discussions on what are the different components. The crisis center gets a lot of attention because that's probably, the most takes, the most, financing and just most people at the table to actually build something like that. But then it's important to talk about, well, then what would that crisis center do? Who does it serve? Many communities kind of get, we see mistakes because they'll build a fancy crisis center, but then it only can take people who are voluntary, who aren't too agitated, who don't have substance use concerns, et cetera, et cetera. And then a community is like, well, why do we spend money on this crisis center when our ERs and jails are still full of people with behavioral health needs? And so, really discussing who needs to be served and what are all the different components of the system and the continuum that serves those people is really important. And the post-crisis part, crisis doesn't just flip off like a light switch. And so there, not only does there need to be easy access, 988 has sort of been front and center of people talking about that easy access, but then on the back end, there needs to be connection to the rest of the mental health system and making sure that people don't fall through the cracks. And then the clinical practice. We haven't really gotten to this point in our learning communities yet, but this is where you talk about a lot of the things, especially the clinicians and groups like this, really start to say, well, what type of care do we want to provide? And again, who are the people that we're providing services to? Not who do we want to provide services to, but who shows up on the crisis system that needs us to provide services to. So that's where we talk about, having competencies in things like substance use, because so many of people in mental health crisis have a substance use crisis and vice versa. So needing to have that co-occurring people, trauma-informed care, for example, or people with developmental disabilities. So making sure that we have the best practices for all these different populations. And this is just, we have like all these cool graphics in the report, but this, one of these things that kind of shows how, in the report, we talk about this Mr. Y, who's like a real patient actually, that was in Baltimore. And how he just had this bad experience in the system. And we talk about how if you had a system in place and how all these things could wrap around that person, then they could have had a much better experience. Do you want to take the tools, Ken? Or you want me to do the tools?
Sure. Well, it's up to you. Yeah, you're doing fine. Keep going.
Yeah, so there are various tools in the roadmap to help communities. So there's kind of a 10 steps for communities to take which 10 steps for system leaders and advocates, of which this meeting, I think, is one of the steps. So yay. There's examples throughout of successful local crisis systems that have done things. Sure, y'all have probably heard me speak about Arizona. So yes, we're in there, but there are other communities as well. Some of whom are in the learning communities with Bob and with Douglas County. And then there's the report card, and this is something we've been actually kind of using that learning community to kind of pilot using this because we really wanted to have a way for systems to assess where they're at. And so all of those slides that I kind of skipped that had all the detail, there's like items for these on this report card. And it's meant for communities to go through there and see, well, do we have this? Are we developing this in the early stages, or have we not even thought about this yet? Not to like grade people and, like grading the states kind of thing, but for communities to be able to use that as a tool to say, okay, these are the things that we should then get a work group on and start working on and start figuring out. And the learning community has actually been really helpful for us also in figuring out of, maybe we need to, make some tweaks to make it more user friendly or do like an abbreviated version. But it's really meant to be a self-assessment tool to lead to discussion and planning. These are all of our 10 steps. I don't know if do you want to go through all the steps or just, okay?
No, I just so you know, there are 10 steps and you can start taking one. And as Margie said, step one, identifying community partners. That is one of the things that Bob has already done with other groups, but the goal here is to bring Cjcc into this discussion in an organized, structured way, because it does overlap with so much of what's important in your work. And then step two, which would be read and process relevant sections of the report, develop your local vision. That, we're introducing you to the report so you know what we're talking about and how you can use it. What we really want at this point is to kind of hand it back to you guys to think about what you want to do with this information. You can ask us questions. You can ask Bob questions. Bob can ask you questions. I'm not sure of how, we just wanted to set the stage for a conversation. And Margie and I can help you do a deep dive into any aspect of this that you want to think about today and think about what your objectives might be going forward. Bob, is there anything that you wanted us to cover in asking us to do this that we did not cover, or anything you want to talk about in terms of what you're hoping to accomplish from this meeting?
No, I think you did a great job setting that up and giving us the things that we need to know in terms of an overview. Let me see if I can tee up what I think our core team has been talking about as we've moved through the learning community process. And that is that when you think about all of the components that we are currently bringing online, right? So as Dr. Minkoff has said, it's turning this sequential intercept map that you've seen before and our eyes sometimes glaze over with its complexity, and trying to sort of simplify that and to say, these are the major components of a crisis system. We started this conversation with, let's build a crisis center. And our behavioral health and healthcare and housing partners kind of formed a coalition, that didn't kind of form a coalition, formed a coalition to do the best job we could at bringing medical, behavioral health, substance use, all of these pieces together in a crisis center that we know is not going to be a magic bullet unless it's surrounded by these other components. So I think our challenge is to think about bringing stakeholders from the Cjcc together with stakeholders from the Behavioral Health Leadership Coalition, and city, county, law enforcement. How are we going to convene a table and conversations in the way we've done over the last 4 or 5 years with our Behavioral Health Coalition partners, so that we can talk about this entire system of care? Our healthcare plan is, our goal in the behavioral health plank of the CHIP is to build an integrated system of care that moves from crisis and illness as a norm to recovery and prevention as a practice. We've got all these components: specialty court dockets, assertive community treatment, AOT, integrated care coordination, the crisis center 988, a dedicated 24/7 crisis line, the mobile team that deployed this past weekend in conjunction with what's happening with 988. We have to bring these components together, and that's going to require some serious conversations, some thoughtful planning, and community-specific strategy. So, I think that's the opportunity before us, and I'm curious to know what members of this group see as potential starting points or monkey wrenches or opportunities.
Shay?
So I don't want to address that point, but I did have a question on the slide you just had up. There were some percentages across the bottom and on the right-hand side. Are those numbers what you are perceiving we could get from that, or where did those numbers come from?
So these are the measures, right, or the targets that you should be aiming for in an ideal crisis system.
These
So-
are actually, they're actually real numbers from the Southern Arizona crisis system. So this graphic is or a version of this graphic is in the roadmap, but it was based on the Southern Arizona crisis system. So those are the actual numbers too. I mean, they're rounded. It's like, 71%, 70 looks better, but I mean, they're essentially real numbers.
Yeah, and Bob, what the population of Douglas County is, again, 100, 200, something like that, 1,000?
122,000. State of Kansas does not have Medicaid expansion. These components are
Right,
fundamental
so-
baseline.
Yeah, so one of if you're looking at benchmark data, which is just in relationship to everything about this, is really not as available as you would think. For a county of 122,000 people, you would expect that roughly 250 adults and maybe 50 youth would have a behavioral health crisis need in any month that would go beyond what could be resolved on a phone call. And so the continuum of service, and then one of the things you look at is, a lot of these are being inappropriately encountered by law enforcement, and even more people just go to emergency rooms, medical emergency rooms, which are not designed to do that response. So as you're building your continuum, you want to build it with the vision in mind that law enforcement should only be involved when absolutely necessary. Behavioral health crisis should be clinical first, and medical emergency rooms should only be involved when there's a medical reason for that. And behavioral health crisis should be behavioral health crisis first. And so you're using these data, primitive though they may be, as guidance for how you design your system. And as Bob is pointing out, you've learned something as a Cjcc about sequential intercept mapping, and you want to be sitting at the table with other partners, not just behavioral health clinical partners, but hospital systems, local funders, Medicaid, and say, hey, we're designing something that's supposed to meet the needs of our whole community, and we want everybody to contribute, because the more contributors there are, the smaller each contribution is, and the more we all share the benefits of our shared system.
Bob, are you envisioning, this is Pam Weejan again, are you envisioning that this group's going to be the one that does the self-assessment, or are these the ones that are going to be looking at the 10 steps? I'm trying to understand what we're doing exactly.
Well, I think we're trying to energize the stakeholders on this call, right, to think about the answer to that question, Pam, and to figure out how to, obviously, we can't do all that work in this meeting, once a month, given the agenda and the scope of this group. So it's how do we thoughtfully assemble a table of leaders? And I think in this level, it's that accountability, finance, governance of the overall system. Where does that live? And who needs to be at the table? And what is each stakeholder's role? What can they contribute? As well as what can they expect in terms of what the system ought to be able to deliver and how it ought to help your piece. So this morning, for example, you know that because you were on the call, Pam, we had the CIT Council starting to talk about how we're going to work through the report card in the system array space. So I think CIT Council plays a good role in doing that. I think BHLC will have a good role to play in the clinical practice question. But for the stakeholders on this call and others who are not on this call, how do we move forward with having thoughtful, intentional, strategic conversations about governance, accountability, and finance for the system?
And let me add, Pam, because it's a great question. This kind of question that Bob is bringing to you as a group is a very important strategic question that's emerging all over the country. So in your community, I'm guessing, as in many communities, the whole question about gaps in behavioral health crisis response tends to start in groups like the Cjcc doing sequential intercept mapping and looking at intercept 0 and 1, as you did in the diagram that was shown earlier. And what you realize is that's inherently backwards. I mean, the problem is that the organized group thinking about behavioral health crisis response is criminal justice and law enforcement. And the ultimate solution is that it can't live there. So at some point, the Cjcc that says this is important, and we need a different group within which we contribute and participate to be addressing this issue for our community with other partners that, like the Behavioral Health Clinical Leadership Group that Bob is talking about, that really own responsibility for this response. As the Cjcc, we have lots to do within all those other intercepts, but we are important partners in this thing. But we want to be figuring out what the right structure is for managing this process for Douglas County. And there is no perfect answer, but beginning to raise this question early on and bringing the right people to the table who carry that leadership capacity and can bring important players and funders to the table, that's a really good discussion right at this moment for you guys.
And I'll give you kind of an example because it can evolve over time too. Like, so in Tucson, when we had our old like regional behavioral health authority, that is kind of the Medicaid managed entity that sort of acts as the accountable entity. Back when they first created the crisis center, that was created by the county and it was driven by justice concerns. And so there was this justice mental health, I forget what it was called. Was when I first moved here, there was this justice mental health coalition type thing. And the Medicaid people attended that. But it was really like the county and the justice system kind of driving a lot of the crisis work at the time. Now, as things have evolved, it's the different regional behavioral health authority that's the managed Medicaid entity, but they have much more ownership of the crisis system. And then the justice folks attend kind of their crisis collaborative. So it can, depending on like who's at the table, the early adopters, it can evolve over time. Because like Ken said, oftentimes in the beginning, it's the justice system that is like, oh, we got to do something about this crisis thing.
Patrick, you have a question?
Not a question. I'll just say that, we've been somewhat fortunate in that well before my time, there was a lot of conversation between my predecessor and the sheriff's predecessor about how to improve the system of care. They worked a lot with Craig, Sarah's predecessor, on that. And yeah, there was a lot of focus on what is now the TRC, but along the course, there was also a lot of conversation about we can't spend all of our money just on some big building, because then that's the only thing we're going to have left. And so the vision started that we needed to add more and do more. And so some money in that original 1/4-cent sales tax was with the idea that we'd be able to create a mobile system of care. Of course, the co-responder had started about the same time I started here, which of course means it predated my time. And so I think we're pretty fortunate. And I think as we've talked about how do we move this forward, there was a lot of discussion by Sarah and Bob. It's like, we also need to integrate the Cjcc into the leadership role of this, because BHLC was out there, but without Cjcc, we're missing such a huge component. And so I think what I hear is a call to us to be ready to for some of us to get really involved and connected with the BHLC and the CIT in a very meaningful way to how to develop this other system that surrounds the TRC. And I'm really excited about that work. So thank you. And hi, Dr. Minkoff. I don't know if you remember, we worked in Iowa together quite a bit. So good to see you.
Yeah, I remember. Thank you so much, Patrick. That was like, I figure Bob must have paid you $10 to chime in with those remarks right at this moment.
That's the cool thing with this coalition is we've started replacing each other's thoughts. So, that's what happens when relationships build, is you start to have shared purpose and shared thinking.
So Bart has his hand up, I see.
Yeah, thank you. And thank you for the presentation, Dr. Minkoff and Margie. Margie in particular, thank you for that component, the example in Arizona you just gave. As far as I'm understanding, it's where it lived was their version of the Cjcc, and then it was a soft handoff to that other component. And I was just wondering, what was the timeline in that sort of soft handoff, or how long did it take to build up an infrastructure so that it could be driven by that more behavioral care component?
Yeah, well, here you kind of had a forced timeline because they put the Regional Behavioral Health Authority contracts up for competitive bid every so often. So when the new REBA came, I think over the course of a few months, they said, we're going to create this crisis coalition. And so it was kind of part of that. So sort of an artificial timeline. But I think it was all the same people at the table, though. So I don't know if that's super helpful, but I mean, it was probably over the course of about 6 months, but it was part of this, kind of new group coming in and being in charge of the Medicaid component of it. But I think because there was a crisis system, I mean, it's a lot more robust and sophisticated now, but there was a crisis system there that they were responsible for, and the people were already at the table, so they just kind of took that on. I think the justice group I think they do other stuff now, and they don't just oversee crisis. They're working on these, so they still exist, and they're just working on other stuff.
Margie often points out that it takes, the history of the full development of the system in Tucson in particular, took more than 10 years, close to 10, 15 years. And we like to emphasize that because everybody wants everything all at once. And part of what Patrick pointed out, and this is really important, is that it's not just the implementation of various components, which is often the thing that folks focus on, but the operation of all the components as an organized system in a continuing way. That's a critical feature to think about early rather than late. So the crisis system isn't just something you create and then you walk away and it operates on its own. It needs constant attention from all of the partners in order to function properly through the lens of continuous improvement. And you are in a perfect position right now as your actual components are coming online to be putting that structure together So you're building not an implementation thing, but a long haul operational thing that maximizes community response and reduces unnecessary pressure on the justice system for people with behavioral health needs.
Do we have any more questions or comments? And Bob, will you be following up with this group in terms of who's going to be on this multi?
Yeah, I think we need, a couple smaller conversations to thoughtfully assemble, a list of potential participants. And, it took us a while to do this with the Behavioral Health Leadership Coalition. It's going to take us a while here, but we're at a much better starting point here than we were 5 years ago at the Behavioral Health Leadership Coalition. So I think that's what we're trying to do. We want to go from, community of learning as a learning community to learning as Douglas County. And then we'll sort of transition into that community of practice.
Oh, sorry.
Just one other thing
Yeah.
I wanted to say
Yeah.
was, to Ken's point, is, we all, as we bring these components on board, as we hold our organizations together and deal with all the transition that's coming out of the pandemic, our bandwidth to have these conversations is stretched very, very thin. I think another ask of this group is to really commit the time and attention and the space to be able to be thoughtful, so we don't have to keep reassembling this system. This is really the moment in the season to build this from start, so we don't have to backtrack and say, why doesn't this component fit in, or why is one agency kind of acting in a silo? We have to work through this collectively.
Yeah.
Yeah, and I would just recommend as well that the CJCC formally designate a subgroup, call it the Intercept Zero subcommittee, to be a formally designated representative participant in the group Bob is pulling together, so that it's not people just as individuals, but that the collective impact of the CJCC has a place at the table, and there's formal representation and communication back and forth, which makes it actually more efficient to do what Bob is saying.
Sarah?
Yeah, and I'd say that was going to be, I just want to underline and put exclamation points under what Bob said in terms of the ask of the CJCC, is that, while I appreciate everyone's bandwidth is at capacity, in order to do the things that we've said we want to do as a community, we will ask you to be engaged again at another level to continue this work. And it's really, it's different than just this piece of the CJCC, and it's different than just behavioral health. So if you're a stakeholder and you're on this call and you're unclear about where you'd play a part in this role, let Bob or Katie or I know, and we can get into a little bit more detail into what we need from each stakeholder and how a new group would be structured.
Or Patrick.
Agreed, yes.
Doris?
So a question for you, Bob, as you guys are problem solving this through, is this going to be like a somewhat of a pilot program at the beginning, so that you can benchmark from either, as you talked about, Arizona? So how would it actually work? As I look at the diagram, it looks like you guys are problem solving at first, and then trying to figure out, okay, so what does it really look like for Lawrence?
Well,
So
what
can
I
you
would
answer,
say,
please?
Doris, is I think we're well on our way to bringing these, 988 launched in July. Connection and deployment with the mobile team launched this past weekend. So all of those components that you saw are coming online, season of implementation. And I think, again, it's time to figure out what are the questions we want to ask in terms of accountability and continuous quality improvement as we do this, so that we're very focused about how we're measuring the impact and the effectiveness of this system.
Yeah, and I would add to that, we have already brought on online some of these things. And so we're kind of midstream problem solving and trying to figure out how we better move it forward in a more coordinated way. Because like I said earlier, some of this stuff we've been doing and standing up and sowing the seeds, and now it's starting to sprout. Now we're starting to realize there's some other things we need to really pull together to really make this grow the way we want to, and be more intentional about including more aspects of this. So that's, I think that's what we're looking for now.
And to help for possibly sustainability as well as you go through the process?
Absolutely, because without a more coordinated way, it won't be sustainable, because we'll continue to step on each other and get in the way. And one thing I want to say, when Bob or Sarah said earlier about the extra time, and the reality is, at least in my perspective, we invest the time now to avoid spending a lot of time later having to clean things up and fix errors that we didn't pay attention to. So to me, it's worth spending that time now, because it's really, again, part of that investment. It's just going to grow and reduce our issues down the road and result.
you.
Yeah, and let me point out,
result in much better
let me
service.
point out in the sustainability domain, Bob alluded to this, but you've built most of what you've created with local dollar grant, county dollars, the local tax, and so on. You've kindly let all your health insurers off the hook. So think about whatever your whole health insurance coverage is, and think about all these lovely services you're bringing online. Should you or your family member need those services, it's unlikely your insurance company will actually pay for them. They'll happily not pay and have the county pay instead. So as you're thinking about sustainability, you want to think, how do we bring insurance partners to the table? How do we bring in Medicaid and how it operates, in terms of what its local impact is here in Douglas County? What about our local insurers and local businesses? What about the insurance plan that covers county employees, just to be really blitheringly concrete? Do they pay for these services that we're bringing online? And how do we engage them as partners in that process? So those are the kinds of sustainability discussions that communities get into. And all Margie and I can tell you is, the sooner you get started, the better. Because all we can say is, so many places say, oh, we don't have to deal with that right now. And then 5 years later, they're saying, gee whiz, we wish we had started sooner. And so you guys are so fortunate that you can be exactly where you are right now.
Well, if we don't have any more questions or comments, I really want to thank, we have somebody else.
I was just going to say that insurance companies are actually really receptive to this these days. I think, Bob, you've talked to Matt on our end, who's super Medicaid, he knows all the details, but, once you explain to them what these services are and how they prevent hospitalization and ED visits, they are actually very receptive. So it's just a matter of having the conversations. This is the time to start having those, like Ken said.
And Bert Nash, LMH, our healthcare partners have started those, those conversations locally, but nudging them with a broader coalition of stakeholders, I think, will be instrumental in actually getting us to leverage results.
Yeah, and with Bert Nash's designation as a certified community behavioral health clinic, we are able to incorporate a lot of the cost of at least the mobile response team and some of the other components, TRC, and that in our cost report and payment system. We, as Bob's saying, we really now need to continue to move into the other insurance markets and share with them. And it really would be beneficial if more people other than the ones providing the service said, hey, this is really important to my company, my business. We want you to cover these services because it's long-term going to save us money if a mobile team comes out, serves that person right there in their home, resolves the issue, and they're not transported anywhere. So
Great. Well, Dr. Yelphor and Dr. Minkoff, thank you so much for participating with us today.
Doris, did you still have a question? You still have your hand up. I just wanted to make sure, Pam, before we move on.
Sorry.
I'm good, thank you.
Okay.
All right, moving on to our next agenda item. It's about 988 and mobile response update from Monica Kurz and Edie Harrison.
Well, and
Thank
I
you,
think Pam,
guys.
we were going to have Patrick tee this up a little bit.
Oh, sorry. Go ahead.
No,
Pat.
I know we're running a bit behind, so I won't take up too much time, but I will say I'm super excited to have Monica and Edie here today to talk about the work that they have done around integrating and partnering together on the 988 crisis line and the mobile response team. Several years ago, shortly after I came here, I was able to visit a really strong system of care in another state where there was a great integration of those two systems, and so excited that we are seeing that come alive today here in Douglas County. So with this is Monica Kurtz from KSP HQ and Edie Harrison with the Burton Ash Center. And so I'll let them take it away. Thanks for joining us today.
Yeah, thank you so much, Patrick. I appreciate that. Pam, am I able? I am. So I just put a couple of slides together to help keep me on track. I know that this agenda is always packed, so I want to make sure that we're using our time wisely. So what Edie and I would like to do today is provide a little bit of an update about where things stand with the implementation of the Douglas County Crisis Line and the mobile response. I am going to kind of skip over, since Bob did a really nice job of letting us know kind of where we are placed here. But today, I'd like to give the Cjcc a little bit of insight into where we're at with the crisis line piece of the crisis continuum, and also the mobile crisis piece. So I think that this is also a good opportunity for us to talk a little bit about what 988 is and what it means in the context of folks living in Douglas County. So I'm sure that folks are aware that 988 became activated on all telecommunications providers on July 16th of this year. So we've been up and running with that dialing code for a couple of months now. Just as kind of a brief overview for folks, when someone calls 988, the first thing that they hear is an automated message. And that automated message prompts them with a couple of different choices. Folks can select one if they want to self-identify as a veteran and be connected to the VA's Veterans Crisis Line. So there are about 3 centers that answer that phone line. One of them is right here in Topeka. And when folks self-select that way, they get connected with folks who are well equipped to talk with veterans, but can also help them follow up with the VA system. Now, you don't have to be VA eligible to use the Veterans Crisis Line, but it is an option. I'll let the Cjcc know that we do talk to veterans on a weekly basis. Not everyone wants to talk to the Veterans Crisis Line. Another option that is given to folks is to press 2 to be connected to the Spanish subnetwork. So that is a network of centers that has the capacity to offer 24/7 Spanish language counseling services. And so that's offered right up front for folks. We as a 988 center do have access to translation services, but I think that we can all appreciate that it's easier to have your crisis addressed in your most comfortable language, right? And so that's one of the reasons for the Spanish subnetwork. They're also working to bring online a more robust subnetwork for folks who are hard of hearing or are deaf. So that's another option. And then if you remain on the line, you are connected to your local crisis center, which here in Kansas is us, Kansas Suicide Prevention HQ. We do also accept text messages to 988, or folks can receive services by visiting 988lifeline.org and clicking chat now. At this point, KSPHQ is the only center in Kansas who is handling 988 texts and chats. So we're doing that for the whole state. A little bit of a disclaimer, when you select the chat program, you are kind of asked a pre-chat survey. So just don't be surprised if you're directing folks there and they're asked a few questions before they get connected to a counselor. So the 988 system in Kansas is a little bit complicated, and I think that this is a really important public education point that we have been working with folks across the spectrum on. So when someone dials 988, we operate differently than 911. There is actually federal legislation that allows for personally identifying information about callers to 911 to be transmitted to 911 centers. That sort of authorization does not exist for 988. So in order to protect people's confidentiality and anonymity, that was not included in the initial federal law, which means that instead of being directed to a call center by your physical location or using geolocation services, calls are routed using an area code. So in Kansas, if you are dialing from 316 in a Wichita exchange, you are directed to ComCare of Sedgwick County. If you are dialing from a 913 Johnson County exchange, you are directed to Johnson County Mental Health Center. And if you are dialing from any other phone number, you come to KSPHQ. If we are not able to answer your phone call, then you are directed to the backup network. So I think that that's particularly important in the context of our kind of emergency services conversation here in Douglas County, because it means that that local number that I've put up in front of you now is something that continues to be really important. We're asking for our community partners when they're advertising the Douglas County Crisis Line to go ahead and include our local phone number. And this is so that we are not confusing folks, like I think a lot about our students who may be living here without an area code that would direct them to us directly with the 988 number. So, you know, I think it's important to know that if you do dial 988 and you're connected to a center that's not us, we do have the ability as a 988 center to be able to put in your address information and find your local crisis center. We can connect you there. We can be that facilitator. You know, it is our policy not to farm out any calls until we've met your immediate need, right? I'm not going to have you call in crisis, find out that you don't live within my service area and get rid of you, or we're going to meet everybody's needs. But we can help them identify a local crisis center for future concerns. So how are things going? You know, since I would say like the beginning of the year, because at this point, 2 months worth of data just isn't a ton. So what you're looking at are calls that come into our system that are coded as Lawrence and Douglas County. You'll see that our biggest utilization month for residents in the county was May of this year. We had 270 calls that came in with that identifying number. And then a little bit of a drop off from June and July, but I expect that we'll be seeing those rebound in September based on where we're at just in the first 12 days of the month. So I pulled these for you all yesterday. One of the kind of current expansion projects as we've been getting the Douglas County Crisis Line project up and moving for y'all and for the community is really thinking about how are we better supporting our 911 call takers and better supporting our community, getting their mental health needs met when maybe what they've done is access 911 and that isn't exactly how they can be best helped. So we've had quite a bit of collaboration with Tony Foster over at Douglas County Emergency Services. His data is telling him that they take about an average of about 300 mental health related calls per month. And the goal that we are striding towards together is to divert phone calls that are mental health related, but do not have a medical or criminal component, right? So we're not needing fire, EMS, or law enforcement response because of a safety concern or because of a medical concern, and have those callers offer the option of talking to a mental health person on the Douglas County Crisis Line instead of really talking with the 911 call takers. We know that they are not mental health counselors. They don't have the same level of training. And they also really don't have the luxury of the amount of time that we can spend with folks to help them de-escalate their crisis, find solutions, connect to resources within the community that may kind of serve them in an ongoing way. At this point, I don't have any good estimates about what percentage of calls will qualify. I think that that's something that we'll kind of learn as we move forward. So at this point, we have proposed a call diversion workflow or protocol that would be implemented with the 911 call takers. Some things that need to happen for us to get to the place where we've activated the 911 call diversion program is we really need that workflow and protocol to be finalized and approved by both the emergency services leadership and also our law enforcement leadership administration. It's something that we want to make sure everybody feels very comfortable with so that we can begin this learning process knowing just as much as we can know before we start it. Once we have that taken care of, I think we're really looking at needing to do some training for our PSAP call takers so that they are asking the correct questions and doing those call transfers. And I think that, once we are able to make this work with the Douglas County Emergency Services, we would look to expand this over to KU Police Department. So I'm just going to talk a little bit about our end of the mobile crisis response piece, and then I'm going to throw it over to Edie to talk about her team, because I definitely want her to have the opportunity to talk about all the good work going on over there. But at this point, our intention is to have folks access the mobile crisis response by moving through the crisis line first. So there are, I think, a few different reasons for that. But one of the major ones is, as Dr. Yelphor and Dr. Minkoff shared with you, we know that a good number of crisis experiences or crisis phone calls can be resolved on the phone without having to dispatch that in-person response. And so we want to have the opportunity to see if that's something that we're able to do. So when a caller dials our phone number and they reach the Douglas County Crisis Line, our counselor is going to provide crisis intervention, de-escalation, and assessment for both safety, suicide, mental health, and substance use concerns. If the caller is assessed to be at imminent risk of suicide or harm to others, that's when we're going to contact 911 so that there can be a police EMS response. If we're able to help that person on the phone de-escalate, then it will resolve on the phone with no further intervention. When those two things aren't true, what we are doing is we're completing a mobile response screen and seeing if the person is eligible and will consent to the MRT support. And I think that this is the really important thing to note here, is that we are looking for consent from people first before we're sending a mobile response team to their home. That's important for the safety of our mobile response team, and it's important for the safety and the accessibility, and I think the continued acceptability of the crisis line and of the mobile response. So we think that consent is really important. We make sure that we contact the supervisor for the MRT who's there at the time so that they can kind of approve the situation so that it is something they want to respond to and let us know how quickly they can be there. So we can relay that information to the caller and hopefully stay on the phone with them until someone arrives. So when the person is contacted by MRT, we'll go ahead and end that call, and then we'll connect with MRT on the backside to make sure that we know the disposition of that call. And Edie, I'm gonna, I think, throw it over to you if you want to take folks through what's going on with your team.
Great, thanks, Monica. My name's Edie Harrison, and I work with Bert Nash, and I am the program manager for the mobile response team. As Bob mentioned, we went live on September 11th. So last Sunday, we went live, and going forward, we will be available 7 days a week from 8 a.m. to 10 p.m. And I know you guys know this, but mobile response is intended to respond to people where they are experiencing the crisis, to mitigate the crisis in their home, in the community, wherever they're at. Crisis is defined by the person, and that is a trauma-informed belief that whatever the person is experiencing as a crisis, we will address and help them resolve, utilizing the resources of the community. And headquarters will provide all the referrals currently. We are working on a protocol and a process of how community partners could request mobile response. And that going forward, we'll work with headquarters and the team going forward to identify what that might look like. Since June, we have responded to 48 calls in the community, and most of those referrals were from community partners, law enforcement, and internal Burt Nash teams. Right now, I have 4 teams of a therapist and a case manager, and we also have a peer support person who works about 36 hours a week and will be available to go out on calls and help support the person in crisis and family members and other collateral contacts, other community members that might be involved in this crisis. I work really closely with law enforcement right now, just Lawrence Police Department with their mental health officer, Officer Agidi, and we hired a co-responder who started at the end of August, and she goes out with him during the week, usually 10 to 7, Monday through Thursday, and then 8 to 5 on Friday. We meet weekly to triage mental health calls that they have gone on the previous week. To identify people that we might want to follow up with as the mobile response team, or, Robert will refer people to Heartland RADAC or peer support, or to the mobile response team. So that's what we are doing right now. Right now, our team will overlap between the hours of 12 and 6, just to make sure that we have enough staff in case somebody calls in sick or something. So go ahead, Monica, sorry. So like I said, we're identifying community partners that may might have that need for mobile response. As was mentioned before, we need consent. And so that's where the sticking point is if it's a community partner calling for somebody, the person they're calling about might not want the service. So we're working on how to identify how they can make that referral. Like working with law enforcement officers to enhance their utilization of the crisis line and MRT. There is a dedicated phone number for law enforcement to call headquarters to request mobile response when they go out on a call and they see that it is primarily mental health and there's no criminal component. Using CIT training, I mean, those all speak for themselves. So that's what I have, Monica.
Yeah, I think the only thing I would add is that we are, I think, in a situation where with a statewide rollout of 988, that there is some attention on Douglas County and how we are navigating the 988 mobile response team overlap and some of the decisions that we're making, especially with regards about how to train the mobile team, what the safety of everyone involved looks like, and what the call diversion protocol is going to look like and how that's going to play out in practice. So KSPHQ has actually convened a statewide working group on those topics. And so we will be sharing some of the lessons learned here and hopefully the success stories with that group, so that this is work that can expand outside of Douglas County. I think one thing that didn't make it onto the slides, but I think is really noteworthy and worthy of celebrating, is that several members of Edie's team were actually able to go through our entire counselor training process over the summer. So they did all 8 of our sessions. They did observation shifts in the call room. They did a lot of role plays simulating what those 988 crisis line calls look like. And I know that having that crossover between the 2 groups of people, I think, is going to be something that's really valuable, and hopefully something that we're able to look at and continue. So I know Edie, Jared Otten, who is our crisis line director, who is not able to be with us today, and I are really staying in close communication about what training needs look like. And I think with that, I would invite any questions or comments from the group.
Marielle?
Mariel Ferrero, community member. First, Monica and Edie, thank you so much for this. It's really exciting to see this launch and kind of see the progress. I have 2 questions. My first one was regarding the 988, kind of the call process, and I noticed that there's an assessment of immediate danger, either self-harm or harm to others, and that was routed then to either the police department or the ER. Would that shift to maybe the mobile response team or the crisis and treatment center when we have more availability to take in patients, or is that going to remain a response from our police or ambulance? I just ask that as seeing and being part of answering some folks in crisis, as like those are not like seeing the police maybe kind of propel more of a response, a trauma response in people, or even going to the hospital. So that's my first question: is there going to be alternate responses to an immediate danger to themselves or others?
Yeah, I think that's a great question, Marielle. A couple of comments there. Like we're going to utilize the resources that are available in the community, like as they come online. And so I want to be clear that if someone has a medical need, if they are needing medical attention, we are always going to advocate with them to get that medical attention. If there is something about the environment that would make it unsafe for ED's team to respond without law enforcement, that's something that we're also going to continue to assess for. But I do foresee that as the TRC comes online and as MRT becomes more integrated into the crisis continuum, that we will be able to use those resources more. I also just want to add that the vast majority of our phone calls do not end in 911 or police dispatch, but those that do, the majority of those, we are able to communicate with the caller and to get their consent to send emergency services. So we try really hard to make sure that both that law enforcement are walking into a situation where their presence is known, and that that's what's going to happen, that we're doing that for our law enforcement partners, and that we're also trying to minimize any trauma that may occur as a result of the response to the call. So it's something that we talk about a lot at our center because we do know that it's not always what folks had in mind when they called, for sure.
Absolutely. Thank you. And then my second question is around community outreach. So I know with the implementation of 988, this mobile response, we're getting calls and we're seeing it utilized. Can you take me through what the community outreach and education process has been like for our county, and maybe what we can do as Cjcc members or community members to help get this word across? Because I think I see the value in utilizing this, particular number as the alternate to calling 911 in these situations, or utilizing mobile response. And I just want to see, what education's out there before I'm like, hey, everybody do this.
Yeah, so what we have, I would say that our community outreach has kind of taken two forms. One is we have been offering a series of virtual lunch and learns. So those started in July. We're offering those through the end of September. So the dates are available on ksphq.org. Folks can register to attend that Zoom meeting. And there we're trying to talk to the community. We're trying to talk to social service providers. We're trying to talk to law enforcement. We're trying to talk to everybody and just demystify a little bit of what 988 is and what folks can expect when they call. I would say that there are people on this call who have also been very gracious in helping us to set up opportunities to talk to other community groups or other stakeholders about what 988 is. Hopefully just getting folks getting invitations into spaces where we can start doing some of that outreach. My organization was also the recipient of some monies from the Sunflower Foundation that we plan to use for community education and awareness. That's not a project that I feel ready to describe at this point because we're still in some planning process there. But I would say that it is a passion of mine to think about the fact that if our crisis system and the continuum that we are building is really going to change how folks in crisis are experiencing recovery, that we have to make sure that they are aware of other ways to navigate the crisis system than what they've really grown accustomed to over these last few decades, right? So it's certainly something that is on our radar and one of our priorities for this year of 988. And if folks are listening to this and saying, hey, I think I know somebody who would like to learn more about this, like, please reach out. We'd love to have that partnership. And I also have a lot of printed materials that I'm willing to share with folks if that's something that would be helpful too.
Thank you. I think my agency with the Housing Authority and other social service agencies, even having that on hand at our resident service office or in reach with people, that they have something tangible, would be amazing. And I'm also happy to be supportive. I mean, in any way we can get this out, I think it's very important. And, you know, we know most of, at least in the world of housing, most of our crisis calls are very intense, and we have a lot of our housing navigators answering those questions and kind of fielding that. And so if they can feel like they have an extra layer of support or resource to give to our clients, I think it'll just be even more valuable. So thank you so much. Appreciate it.
Did Patrick disappear?
No, I
Oh.
decided I'll hold my question for a future.
Okay. Okay. Did we have any more questions or comments for Monica or Edie? Really want to thank you for participating with us today. This was really helpful. Congratulations on getting everything rolling. Our final agenda item is a jail population update with Sheriff Armbruster.
Yeah, I'll be brief. We experienced a peak about a month ago, well, during the last month, where our in custody in our facility was nearing the 170 mark, with another 15 to 20 housed out of county. As of this morning, we were at 159 in the building, with another 18 housed out of county, and I think it's like 8 or 9 that are off at either like Larned State Hospital or Squattamy State Hospital or some other treatment facility. We are housing people in places that they were never intended to be housed. Everybody has a mattress and a bunk, but it's not where the way the building was designed. We are over our capacity, our functional capacity, as you've heard me drone on about, is they're 135-ish. And we're at 159 today. So I also wanted to update everybody about competency evaluation and competency restoration. So the state has stated that they're going to put some money towards doing, to make sure we're all on the same page, this is where a person has been charged with a crime, almost always a very serious crime, and the court has found them that they need to be evaluated to see if they're competent to assist in their defense or stand trial. And if that is a question, they're sent to Larned State Hospital for that evaluation. They are either regain competency or they come back, and the court handles it there. The problem is that wait time has been from the moment the judge says, yes, you need to be sent to Larned State Hospital until they actually go has been about a year. So that's a person who is in our jail awaiting within the justice system to just go to find out if they're able even to go to trial. And after a year, they stay there for a month, they come back, and then the court process starts over. We have 13 people on that waiting list, people who are waiting to just go and find out if they are able to even help with their own defense. And so the state, we've kicked a few special trash cans, I believe, up in Topeka, and got some movement. And they want to start bringing the doctors into the jails. So kind of like the mobile response, bring them where the people are instead of sending the people where they're not. But the thing is they're only willing to work with med compliant people. So out of our 13 folks who are on our waiting list, 4 of those folks are med compliant. So therefore the state will come in and work with those 4. We have not seen a lot of movement and traction on that, but the ball is rolling in a positive direction. So that's still, this is not the magic bullet. the state has got to do some very heavy lifting to get this. I have a uneffed, I believe is the censored version of the word that I would use, because the system is completely broken, and the longer it continues to be broken, the deeper people are going to fall within it. So you look at there's a young man who has been accused of killing his wife, and he is sitting in our jail for upwards of a year before we can even get to see if he's able to stand trial. So this has been a real problem, and these people are extremely resource intensive, and they're frankly difficult, and they're dangerous. Clearly, that's why they're in my building, and so we have got to get something figured out. So that's just it's something, but it's not fixed yet. So if anybody has any questions or anything, you can always reach out to me. But that's really kind of the 10,000 foot update from the jail.
Sheriff, I just didn't know if Katie, you want to talk a little bit about our plans to pull together jail review.
Sure. So we are, I have a couple folks that I need to circle back with about availability to schedule kind of a follow-up kickoff meeting to start working through what a process at the individual case level review and kind of larger policy level, policy or practice level review of drivers of the jail population could look like that we could implement here in Douglas County. So we are looking probably towards the end of September to kind of pull that group together and start a more formal or more standard and regular review in the weeds, and then also kind of the 10,000 foot view to help reduce where we can the pressure points that are driving the jail population.
Patrick?
I'll just add to what the sheriff was saying, and that on the mental health center side, there is a lot of movement with with a handful of mental health centers around competency restoration, and we're working with KDADs on some ideas and projects specifically around that, in Douglas County being one of the high population areas for individuals who are incarcerated while waiting for a time to be at Larned. Is fortunate enough, unfortunate, I guess, that we're that so high in that number, but fortunate enough that it's being recognized that we'll be able to hopefully down the road be part of the solution and helping our population improve its health and be able to move forward properly in the system.
Suzanne?
Yeah, I just want to emphasize that, the jail makeup, we've been watching it as well since the spring when we were coming out of COVID and the numbers started to rise. And we're looking at it every week to see if there's anyone that we can certainly be a little bit more lenient on in terms of maybe pretrial release or those kinds of things. But I will tell you that based on those being held on district court charges, these are serious charges. And as the sheriff has indicated, those that are being held for mental health evaluation also are charged with various serious crimes. So we have very little wiggle room. I just want to emphasize that we're not holding people, at least on district court charges, for stealing a bicycle or, smoking weed. So every little, help we can get, not only from, of course, what we're doing, but the city as well, in terms of who's in the jail on municipal court charges, would be extremely helpful. So this jail review committee, I think, is going to be very important, and I'm glad that we're going to convene it, because this will give us an opportunity to really know who's in our jail and what we can do to make sure that only those that need to be kept there, being held there, et cetera, for serious court proceedings are in our jail.
Yeah. Thank you for the update, Sheriff Armbruster. I think we have a couple of announcements. Katie, I'm going to leave that to you.
Thank you, Pam. I just had 3 things I wanted to share with you all. The first is that the drug court is hosting a recovery walk in a couple of weeks. I'm not sure how many of y'all have kind of seen seen anything about that or would be part of that circle, but on September 27th at 6:45 in South Park, at the east end of South Park, there will be a recovery walk with luminaries. They're going to have all sorts of games. I know Shannon Berge has been working on like Plinko, I think was one of the things when I was over there last and saw that. So just as an opportunity to celebrate the recovery efforts and the successes of those participants. If you're able to, I'd encourage folks to go out and attend that Tuesday evening. The other reminder I sent out last week, the final draft of the law enforcement contact study from Northeastern. Jack and Janice would like feedback that we have by tomorrow. So if anyone has feedback, I would encourage you all to send that to them by the close of business tomorrow. And in October, I will be sharing probably briefly a survey that I'm drafting between now and then to be able to get feedback about the direction of kind of the CJCC as we start wrapping up 2022 and look towards how our work will be driven and what we want to focus on in 2023. After that, I'm anticipating sharing that survey with all of you all in the community members after the October meeting to start being able to spend the last couple months of the year drafting and pulling those results together to help us decide our next steps. So I just want to put that out there, and there'll be more about that I'll share in the October meeting. So that was all I had, Pam.
Thanks, Katie. I think we're moving to the public comment section. Do we have any public comment or questions out there?
Yes, we have a hand up. I'm going to allow them to speak.
Great.
Yes, thank you. This is Jagan, part of the Justice Matters Jail Alternatives Research Committee. Just curious, in listening to the sheriff's report, I think there were really two things on my mind. One, I think you answered, which was that I heard 13 inmates are waiting competency evaluation out of your 159. Is that correct?
Yeah.
Okay, so I mean, that still keeps you above your kind of threshold of population. But the other question,
I don't. Those people are. I mean, they're with me for over a year while they await to go and find out if they're competent to stand trial. So
right.
I don't know what threshold if you're talking about my functional capacity, but they're resource intensive heads in beds that are with me for over a year before they can even come back and start their process.
Yes, yeah. So I mean, but even if you could process those, you would still be above your capacity, technically.
Yes.
Yeah. So the other question was wondering if you would wager a guess or if you know definitively what percentage or what number of your inmate population might be attributed to sentencing from the Lawrence Municipal Court.
Oh, I'd have to do the numbers, but I can tell you it's a low percentage as far as sentencing. A lot of them are being held on failure to appear through the municipal court, but of course they typically only hold the folks who also have a district warrant. But I can tell you one person who is in our jail for let's see, less than out of the last 4 years, I believe Robert Gilmore has been in our jail every day except for 4 days in the last 4 years. And every day of that has been for the municipal court sentencing. He has spent every day in our jail. Over the last 9 years, it's like he's spent 8.7 years in our jail on municipal court. But for the most part, there are not that many people who are simply serving time for the municipal court. But I could get you that number, a definitive number. We do track that, and I could let you know what that is at a later time.
Yeah, that'd be great. And but also kind of interested in the nuance there on the number who are there for failure to appear.
Okay, I believe, so Dr. Cravens actually tracks all of that, and I don't expect him to have to jump in here, but we do track those. We get weekly reports on municipal court inmates that are in our current facility, and how much the city is paying for each of those persons, reimbursing us for holding them. So we have all those. I just don't have them with me, and frankly, I'd have to have somebody much smarter than myself to really kind of read them to both of us.
Yeah. Okay. Well, thank you for the response, and we'll look forward to hearing more. Appreciate it.
Do we have any other questions or comments? Leah?
No.
Great. Do we have anything else for the good of the order today? Seeing no response, I'm going to adjourn this meeting, and the next meeting of the CJCC will be on October 11th. I'll see you all then. Thank you for attending.